So we are going to discuss the examination of cardiovascular system. You see, whenever you examine a particular organ system, we basically divide it into two components. The general physical examination, which is relevant to that particular system, and the system itself. So for the cardiovascular system, the general physical examination is generally divided into the areas: hands, wrist and arm, neck and face, legs and back. What you want to see in the hands is the clubbing. Clubbing is present in the cyanotic heart disease and chronic infective endocarditis. Second thing we look in the hands is the cyanosis. This is the bluish discoloration of the fingers and nails. If the fingers and nails are cold and blue, this is peripheral cyanosis. But if they are warm and they are blue, this is most likely central cyanosis. Then we look for the signs of the chronic infective endocarditis, that is the splinter hemorrhages in the nail bed, the ocellular nodes, which are tender nodes in the pulp of the fingers, and we see hyperpigmented Janeway lesion in the palm. These lesions are seen in some 8 to 10% cases of chronic infective endocarditis. They are not seen in all cases. Then we come to the wrist. By wrist we mean the examination of the radial pulse. Radial pulse is examined with the forearm slightly pronated and wrist slightly dorsiflexed. We calculate here the rate, we look for the rhythm, the volume of the pulse, and one character which can be examined in the radial pulse is the collapsing character. That's you hold the radial pulse in your palm and then lift the arm suddenly. The pulse keep on striking the palm. This is collapsing pulse, which is seen in aortic regurgitation and patent ductus arteriosus, and similarly other conditions with high cardiac output states. And then we examine the arm for the presence of blood pressure. In the pulse, just remember that you have to examine the radial pulse in both left and right arms, and you have to examine the pulse in the carotid area, the femoral area, and the feet, that is the dorsalis pedis and posterior tibial arteries. And we compare the radio-radial or radio-femoral delay if they are present. So they have certain significance. So you record all these pulses. And then in neck, you see the arterial pulse, the venous pulse, and the presence of thyroid gland. That whether the goiter is there or not, or there is a bruit on the thyroid gland or not. And you check the carotid and the jugular pulsation. We will see that in the JVP. Then on the face, look for the presence of facial swelling, the pallor or jaundice. They are present. You can see malar flush in cases of patients who got pulmonary hypertension, which is because of mitral stenosis. That is called mitral facies. And you examine the legs, as I mentioned, for the dorsalis pedis arteries. You look for the presence of dependent edema, that is pretibial edema. If you press the tibia for 30 seconds, you will find a pit in that. If that pit is present, that means there is dependent edema. And then you look for the presence of distended veins and the presence of signs of deep venous thrombosis, that is swelling of the leg with increased temperature, and there may be tenderness. And similarly, you look for the back for the presence of dependent edema on the sacrum, that is called presacral edema. This is seen in patients who've got fluid overload state and they are bedridden. In the mobile patients, you look for the edema in the legs, that is pretibial edema, and in patients who are bedridden, you look for the edema in the sacral area. Now we come to the JVP. When you see pulsations in the neck, you have to decide this is arterial pulse or this is venous pulse. Now we can do this on inspection and palpation. And we can do a maneuver. On inspection, first of all, we see the line of pulsation. The jugular pulses, they are start from the sternoclavicular joint and they go towards the ear, because the internal jugular vein, which lies in the carotid sheath, is in the line with this sigmoid sinus which continues as internal jugular vein. So this is the line. And if the earlobe is moving with the pulsation, this is nothing but jugular pulses. And the line of the carotid is from the sternoclavicular joint to the inside of the angle of jaw. So it's the inside, while the jugular veins pulsations are going towards outside. The jugular pulses may have an upper limit. The arterial pulse usually does not have an upper limit until the carotid is obstructed. So jugular pulses may have or may not have an upper limit. And then the pulse is a single expansile pulsation. It expands like this. While the jugular pulses, venous pulses, they may be double and quivering like that. So they are not expansile, they're quivering like that. And the jugular pulses, they vary with respiration. They may fall with respiration, they may rise with respiration. For example, if normally what happens when the patient inspires, there is negative intrathoracic pressure which becomes more negative, the blood is sucked into the thorax and the JVP falls. While patients who've got cardiac tamponade or those who have got constrictive pericarditis, when they inspire, this is a paradoxical phenomena, the jugular pulse rises. So this is called Kussmaul sign, while the respiration does not affect the arterial pulse. So these are the things which you can see on inspection, and then you can palpate. The jugular pulses are not palpable, while the carotid pulse is palpable. Now, where to palpate the carotid pulse? It is the common carotid in the neck which is palpated. It is palpated at the level of cricoid cartilage at the anterior border of the sternomastoid. The left carotid with the right thumb, the right carotid with left thumb, and never both simultaneously. So this is how we examine the carotid pulse. And at the carotid pulse, you can also note the character of the pulse, because the character, as I told, the only one character which is examined at wrist is the collapsing pulse. The collapsing pulse cannot be examined at the carotid. It's only the anacarotic or dicrotic pulse which can be examined at the carotid area. And then we can do a maneuver. When you press the upper abdomen and the right hypochondrium, the JVP may rise because the blood stored in that liver, when you press it, it is shifted into the vena cava. So you may see that the JVP starts rising. This is called hepatojugular reflux, and if this is present, this means there is the pulsation which we are seeing is venous pulse. Before we go to the precordium, we discuss a little bit of the jugular waveforms. In jugular pulse, we see these three upward waves, and you can see three downward waves: A, C, and V, X, X dash, and Y descents. So A wave, this is because of the atrial contraction. When the atrium contracts, the pressure in the atrium rises. There is no valve between the right atrium and the vena cava, so the pressure is transmitted back into the veins. This pressure is seen as A wave because of the atrial contraction. And when the atrium, after contraction, it relaxes, the pressure falls. This is called X descent. And as the atrium is relaxing, the ventricle starts contracting. The ventricle contracts, the tricuspid valve moves upward. So this C wave is produced because of the contraction of the right ventricle. And then as the ventricle contracts further, the ventricle shortens. It has a certain stretch on the tricuspid valve. So that tends to come downwards, and the pressure in the atrium falls again. So this is called X dash descent. This is the second descent because of the contraction of the right ventricle. Blood is flowing into the atrium. Now the atrial pressure starts rising again. So this is because of the venous return coming into the right atrium. And when the ventricle relaxes, the pressure in the ventricle falls. The blood suddenly moves from the atrium into the ventricle, producing this Y descent. So these are the negative waves: the X descent, the X dash descent, and the Y descent. This positive wave is because of the atrial contraction. This is because of the ventricular contraction. And this is the continuous venous return coming into the right atrium. This is because of the atrial relaxation. This is because of the ventricular contraction. And again, this descent is because of the ventricular relaxation. So these are different waves. Now, practically, when you're examining JVP, the C wave is so small that is difficult to appreciate. So what you can see normally is you can see an A wave and a V wave. So we see three positive waves, three negative waves. This is because of the atrial contraction, this is because of the ventricular contraction, and this is because of the venous return coming into the right atrium. This is because of the atrial relaxation, this is because of the ventricular contraction, and this is because of the ventricular relaxation. Now we come to the precordium. We do inspection, palpation, and auscultation. Percussion is not usually done in the precordial examination because it gives us a little information, so that's not useful. On inspection, we see the shape of the chest. See, there are certain conditions in which the chest may be bulging outward, for example, that's called pigeon breast. And then opposite of it is the pectus excavatum, when the chest is depressed. Or look for the presence of scars. Midline sternotomy scar means cardiac procedure has been done. And then you've got intercostal incision on the left side. This may have been done for the esophagus, for the heart, or the pericardium. So you have to see, to note down if there is a scar present in that. If this scar is present, some procedure might have been done on the heart. And then you locate the cardiac impulse. Is it visible or not? How is the precordium? Is it moving or it is not moving? If it is moving, then try to note what is the pattern. But you see, you've got left heart dominance, right heart dominance that can be appreciated on inspection. For example, if there is a left heart dominance, you would see the apex moving out, sternum moving in. And in right heart dominance, the sternum rocking outside and the apex at the same time depressing inward. But if there is no dominance of the ventricle and there is diffuse enlargement like cardiomyopathies, you may see just moving the precordium and you can't make a definite pattern. But if you've got isolated lesion, for example, you've got uncontrolled hypertension or aortic stenosis, you may find this left dominance. Similarly, in isolated pulmonary hypertension, you may find a right dominance. This may be seen on inspection. But again, the next step, the palpation, in fact, is the most important in the examination of the precordium. First, we define the apex beat. Apex is also called mitral area. In the precordium, you've got certain areas which are named after the valves, and they indicate the areas where maximum effect of the hemodynamics of those valves can be appreciated. These areas do not mean that the valves exactly lying under those areas. In fact, only the events which are happening at those valves are best appreciated at that particular area. For example, you've got apex where we see mitral events, so it's called mitral area. The aortic one area is on the right side in the second intercostal space. The pulmonary area is on the left side, the second intercostal space. The third space is the aortic 2 area, and the fourth area, in fact the fourth intercostal space on the left side, is the tricuspid area. So you've got mitral area, you've got aortic area, aortic 1, you've got pulmonary area, you've got aortic 2 area, and in the fourth space you've got tricuspid area. So any event which is occurring, for example, at the aortic valve is best appreciated at the second intercostal space on the right side, or sometimes the third intercostal space in the left side. So we locate the apex. Apex is the outermost and lowermost part of the precordium where there is a definite cardiac impulse. To exactly localize the apex, we use two parameters. One is horizontal axis, the other one is vertical axis. The horizontal axis is the intercostal space. And the vertical axis is mid-clavicular line. The second rib joins the manubriosternal angle, and below the second rib is the second intercostal space. So you can follow the intercostal space and you can locate where is the apex beat. Similarly, you can draw a vertical line, that is mid-clavicular line, which intersects this intercostal space, and you can locate your apex beat with reference to these 2 points. The normal apex beat is lying in the fifth intercostal space slightly to the left or to the right of the mid-clavicular line. Now, how to draw a mid-clavicular line? In thin subjects, the acromial end of the clavicle may be seen, but in patients who are well-built or who are obese, this joint may not be visible, this end may not be visible, it is covered by the tendon of the deltoid and fat. So what we do is we take the mid-sternal point and the point of shoulder, and we take the central point of these. This approximates to the mid-clavicular line, and if a line is drawn from here to the tip of the 9th costal cartilage, this is mid-clavicular line, and we can define our apex, whether this is present in 4th space, 5th space, 6th space, medial to mid-clavicular line or lateral to mid-clavicular line. So this is what we can do on palpation. And then we note the character of the apex. It is normal, it is whether it is tapping or it is heaving. Tapping apex beat is just hits your palm like that. And the heaving apex beat is which lifts your palm. If the lifting is throughout the systole, that is from the first sound to the second sound, this is well-sustained heave. And if it is only in the part of systole, this is ill-sustained heave. The well-sustained heave is seen in pressure overload conditions like aortic stenosis and sustained uncontrolled hypertension, while the ill-sustained is seen in volume overload conditions like aortic regurgitation and mitral regurgitation, while the tapping apex beat is typically seen in mitral stenosis. And then next you palpate the parasternal area. You put your palm like this on the parasternal area and see if there is an upward movement of the palm. So that means parasternal lift. If the parasternal lift is present, that means the right ventricle is contracting forcefully and hypertrophied. So this parasternal lift indicates forcefully contracting a right ventricle. And then you palpate the individual areas for the palpation of various events. You may palpate second heart sound, sometimes you may palpate the third heart sound, and you may also feel the very loud murmurs which are called thrills. When you palpate a thrill, you look whether this is a systolic thrill or this is a diastolic thrill. Try to time it, and we time it against the carotid. Anything which comes after the carotid is systolic, and before the carotid this is diastolic. And you may also sometimes palpate the pericardial friction rub. So this is what you do on palpation, and next you go on to auscultation. For the auscultation, you have to understand this cardiac cycle. This is systole, this is diastole. Systole has 3 components: isovolumetric contraction, ejection, isovolumetric relaxation. It means that in this isovolumetric contraction and relaxation, the volume of the ventricle does not change, but the pressure does. When the ventricle contracts, this blue line, the pressure starts rising. When the pressure starts rising, the mitral valve is closed because the pressure in the left atrium is very low. So the first heart sound is produced. And you see, and then pressure starts rising here. Then the pressure in the left ventricle goes beyond the pressure in the aorta. This black line is aorta. So as soon as it exceeds the pressure in the aorta, the blood ejects from the left ventricle. And the left ventricle pressure goes to a peak and then starts coming down here. Now here, the left ventricular pressure falls below that of aortic pressure, and the blood from the aorta goes back into the ventricle, closing the aortic valve. So second heart sound is produced. And then this is diastole, this is rapid inflow phase, this is diastasis, and this is atrial systole. So this is one cycle is completed, systole, diastole. You got first sound when the pressure starts rising in the left ventricle, and aortic valve open when the pressure starts falling in the left ventricle. The aortic valve closes, you have got second heart sound. When there is a large amount of blood which flows in the initial phase, that is the rapid inflow phase, you may sometime hear a third heart sound and a fourth heart sound when the atrium contracts against a stiff ventricle. So you see the third heart sound lies close to the second heart sound, and the fourth heart sound lies close to the first heart sound, because this is the next cycle starts and you got here a first heart sound. So these two sounds occur together and these two sounds occur together, and they will help us in differentiating the different type of gallop when we hear, if the gallops are present. Those you see the S3 gallop or the S4 gallop. So this cardiac cycle helps us to differentiate this is a third heart sound gallop or a fourth heart sound gallop. Now the simple murmurs, we see the murmurs of lesions of the aortic valve and the mitral valve. First we'll see the lesions of the mitral valve. When suppose there is mitral regurgitation, the mitral valve is incompetent and cannot stop the blood from regurgitating back into the left atrium. The ventricular pressure starts rising. As I already mentioned, the pressure in the left atrium is very low. As soon as the pressure in the left ventricle rises, the blood starts going into the left atrium, and this starts producing a murmur. And since the pressure in the ventricle remains throughout the course of systole higher than the pressure in the left atrium, so you hear a pan-systolic murmur. Throughout the cardiac cycle, the pressure in the left ventricle throughout the systole remains higher than the pressure in the left atrium. So throughout the systole, the blood regurgitates back into the left atrium, producing a pan-systolic murmur. What happens in mitral stenosis? That during diastole, a large amount of blood flows across the mitral valve into the left ventricle. So if the blood is flowing from the left atrium into the left ventricle during diastole, this large amount of volume passes through a narrow stenosed mitral valve. This produces a murmur, which is loud in the initial part, and then there is an atrial contraction. This atrial contraction gives a final kick to the blood. So you hear a diastolic murmur which is a late called pre-systolic accentuation. And if there is atrial fibrillation, this late pre-systolic accentuation will be absent. And now we see the aortic valve. When there is aortic stenosis, the left ventricular pressure starts rising and the aortic valve opens here and the blood ejects. So after the first heart sound, there is a little bit of gap period, and this gap is increased in case of aortic stenosis. This is our isovolumetric contraction phase, but this isovolumetric contraction phase is increased in case of aortic stenosis, because the left ventricular pressure has to rise more than it normally does. So, and then the blood ejects from the left ventricle into the aorta. This now ejection produces a sound. This is the ejection systolic murmur of aortic stenosis. And now we come to the aortic regurgitation. When the pressure in the left ventricle falls below the aortic pressure, the blood moves back, and this produces an early diastolic murmur. Theoretically, since you can see the pressure in the aorta throughout the diastole remains higher than the pressure in the left ventricle. This is left ventricular pressure curve. So you see, when the pressure is high, we expect a pan-diastolic murmur, but we practically don't see a pan-diastolic murmur. What we see is an early diastolic murmur. The reason is that there is a small amount of blood in the aorta, and during the early part of the diastole, the large portion of that blood goes back to producing the murmur, and as the diastole passes, this murmur starts decreasing because there is very little amount of blood which is flowing now from the aorta into the left ventricle. So hence we see a diastolic murmur in the early part of diastole in aortic regurgitation rather than seeing a pan-diastolic murmur. So this is what we normally examine in the cardiovascular system. And the complex and individual lesions and details of all these lesions we will discuss when we discuss these individual valves. So this was just an outline that when you examine the cardiovascular system, what you have to look for. You divide it into general physical examination. General physical examination again is broken into certain areas like the wrist and hand for the blood pressure. Then you examine the neck and face, and then you examine the lower legs. And You concentrate in the neck on identifying the JVP, what are the characters of those waves, and differentiating it from the arterial pulsation. And then you examine the pericardium, where you do an inspection, palpation, and auscultation. So this is